Welcome to Lucent Educational Concepts. Let's take a closer look at the differences between diabetic ketoacidosis and hyperosmolar hyperglycemic state. Now, it must be stated that when you take a closer look at DKA and HHS, both are conditions that affect the pancreas. In the case of DKA, it affects mostly patients who have type 1 diabetes. Obviously, they are not producing any insulin at all. So we are saying that there is no insulin production, absolute. And in the case of HHS, the pancreas produces some amount of insulin, so relative. So a closer look at DKA. So again, in simple terms, there is a condition in which, because the cells of the body are not receiving adequate what? Insulin, total no insulin at all. Therefore, the cells have nothing else to do but to initiate the breakdown of fat. And the fat is absolutely going to be used as a way of fuel. And that is what it's termed as lipolysis, which is uncontrolled breakdown of fat. Now, as the fat is breaking down, it leads to the release of ketones, and ketones are also acids. That leads to an increase in the anion gap, leading to acidosis. And obviously, when this entire process escalates, you realize that ketones will be released into the urine, and therefore we can excrete them. One thing that needs to be made clear is that as the process of DKA goes on, you realize that patient begins to retain fluid because dehydration also becomes part of it. So that is why in DKA, sometimes you may see patients gain weight. Let's go to HHS. In the case of HHS, the body becomes, technically, the cells become very resistive to the use of insulin. Again, the insulin making its way into the cell, there's resistance to that. And as a result of the resistance, what happens is that you have an increase levels of glucose in the bloodstream. That leads to the hyperglycemia. And obviously, when hyperglycemia occurs, then you also have the tendency for fluids to be pulled out. That is osmotic what? Diuresis. And when that occurs, patients become very dehydrated, leading to volume depletion. So that is why in HHS, you realize that, especially with type 2 diabetes, patients lose weight. Whilst in DKA, you realize that the patients begin to gain some level of weight. So let's take a closer look. What is DKA? So DKA is, in simple terms, like I said earlier on, it's a serious complication of diabetes that occurs when your body produces high levels of blood acids called ketones. Now, this happens because your body can't produce enough insulin, which is necessary for glucose, that is sugar, to enter into the cell. And I believe somewhere along the line, I may have stated that please always consider insulin as key to open the cell for the glucose to enter in there. Okay. So without enough insulin, your body starts to break down the fat for fuel. That is lipolysis, producing acids, which are the ketones, and obviously that becomes the byproduct of this process. These ketones can build up in your blood, making your blood very, very acidic. And thus, we end up with the condition known as diabetic ketoacidosis. That is not the end of it all. Also, keep in mind that when glucose builds up in the blood, and you realize that osmotic diuresis also occurs because there got to be some pull out of what? Out of the glucose. Glucose is technically, you want to look at it as a body in which there is more of hypertonicity related to that, as opposed to just normal fluid. That could be, instead of it being more hyper, you may realize that it becomes an average. So we are looking at it not hypotonic, not hypertonic, but you're looking at it as an isotonic condition. But glucose is more hyper. And obviously, that leads to the condition known as dehydration. So, as part of our discussion, we need to understand that diabetic ketoacidosis is acidosis plus dehydration. So, as you go forward, answering your questions related to NCLEX, anytime when you come into the context of DKA, remember you are dealing with two things: acidosis and dehydration. Let's move to the second, which is HHNKS. Sometimes we do refer to HHNKS as HHS. Now, HHNKS is hyperosmolar, hyperglycemic, non-ketotic state, which tells you that, especially with HHS, it has nothing to do with ketones. So let's go into our discussion. So HHNKS, also known as hyperosmolar hyperglycemic state, HHS. Seriously, it's a major complication of diabetes, typically affecting type 2 diabetes. Okay. Now, it occurs when blood sugar levels become extremely high. Often you may see them above 600 milligrams per deciliter. Technically, I have seen a patient who came into the emergency room with HHS, but his sugar levels actually was 1,000 in the operating, actually in the emergency room. So keep in mind that in HHSKS or HHS, we have more higher levels of sugar, okay, hyperglycemia, as opposed to DKA, which is more minimal. You may see it around 300. Okay. Now, when HHS occurs, it can lead to severe dehydration and obviously an imbalance of electrolytes. We will take a closer look at what type of electrolytes are affected. So, to make things easy for us, let's look at the key differences between DKA and HHS. And I would say, if I would say HHNKS or HHS, whichever way you want to take it, it's all the same. Nothing changes. So let's look at types of diabetes. Please, DKA, more common in people with type 1 diabetes, but can also occur in type 2 diabetes. We have it more with type 1. Now, HHNKS primarily affects people with type 2 diabetes. So that is stated clearly. What about ketone levels? Now, in DKA, it is characterized by high levels of ketones in the blood and urine that leads to acidosis. And sometimes when you have ketones in the urine, then you have ketonuria. Now, when it comes to HHNKS, it does not typically involve significant keto production. So I would say that seriously with HHS, no ketones. And you realize that when you check your ABGs, arterial blood gases, mostly everything is normal. What about blood sugar levels? In DKA, blood sugar levels are elevated, usually between 250 to 600 milligrams per deciliter. Now, what about HHAKS? Blood sugar levels are extremely high, often exceeding 600 milligrams per deciliter. So, what do we learn from here? We learn that in DKA, sugar levels are lower as opposed to HHS. What about onset? When it comes to DKA, it develops very rapidly within hours. However, when it comes to HHNKS, development technically are more slower, and it can occur over days and to weeks. Let's go straight to symptoms. And the first one has to do with DKA. Symptoms include frequent urination, extreme thirst, high ketone levels in the urine, nausea, vomiting, and the fruity smelling breath, which is also known as the ketonic what breath or acetonic breath. And that is what we all know as Cushman's respiration. Patient may experience fatigue and rapid breathing. That is Cushman's, obviously. Now, the key point over here is why the acetonic breath, because ketones are supposed to be gotten rid out of the ketones, gotten rid out of what? By way of urination. But because sometimes it may not necessarily be we may not be in a position to get rid of them. Therefore, then the lungs takes over and blows the ketones by way of the lungs. That is where then you have your Cushman's respiration. And purely the type of smell over there are acetones. They are ketonic breath. Something you may have what experienced by way of peeing. What about our HHNKS? Symptoms include extreme thirst, frequent urination, dry mouth, confusion, warm, dry skin without sweating, fevers, and sometimes we have AMS, which is altered mental status. And you may see some patients also might lose some vision. When we talk about vision loss, we're talking about blurred vision. And you may see others also hallucinate. So, what is the difference between DKA and HHS in terms of acidosis? Keep in mind that when it comes to DKA, the presence of metabolic acidosis is due to ketone accumulation. Okay. Now, because of the ketonic accumulation, which leads to acidosis, we have a corresponding build-up of potassium. Okay. So when potassium builds up, that then leads to hyperkalemia. Please always keep in mind that why do we have hyperkalemia? Why do we have lots of potassium in the bloodstream? Now, the key point over here is potassium is supposed to enter what? The cells. Anytime when insulin opens the cell, potassium gets in. So the fact is that if your body cannot produce insulin, okay, or even if the insulin is stimulated, mostly with type 1 diabetes, because insulin is not being produced, it means that we don't have anything to open the cell. Therefore, potassium cannot enter the cell. So what happens to potassium? Potassium is kicked out, and potassium is in the bloodstream, increasing and increasing, leading to hyperkalemia. So that is why you always have a clear understanding when we talk about DKA and electrolyte imbalance. We are looking at potassium as the major electrolyte to be concerned with. Now, what about HHNKS? There is no significant acidosis. None. There's no ketosis. That means it has nothing to do with ketones. And again, ABGs remain what? Normal. So this should give you a clear understanding of the difference between these two complications of diabetes. Let's go to treatment. Now, with DKA, always number one, give IV fluids. I'm talking about normal saline. It's the IV fluid of choice to treat the dehydration. It's your first priority. Second priority, give IV regular insulin to treat the hyperglycemia and the hyperkalemia. Always keep in mind that there's always a rapid drop in glucose, because why? It then leads to the pool of water. Okay, and sometimes when that happens, because I said earlier on that, keep in mind glucose it's considered a hypertonic substance. Okay, and therefore it tends to pull fluids out of the cell. And for example, when that happens, think about it in terms of what? Of your brain. If it should occur that because fluid is being pulled out, and therefore we have excess of fluid going into what, into the brain. Then that can lead to what, increase in what, in ICP, which is intracranial what, pressure. Now the normal ICP is 0 to what, 15 millimeters of what, of mercury. Anything greater than that is ICP. Next, keep in mind that during IV insulin infusion, we frequently monitor mental status changes, and we keep our eye on glucose and potassium. So let me repeat over there. So anytime when you're giving IV regular insulin to your patient, especially to treat the hyperglycemia, keep your eye on the glucose. Because what am I saying this? Because you are treating, we are trying to what? To decrease the amount of glucose. Therefore, we can have the tendency of going directly into hypoglycemia. Okay? And at the same time also, because our goal is to bring down, to decrease the amount of potassium, then we can end up also in hypokalemia. So again, it's a catch-22. When you are treating people for something that is higher, you end up with something what? Slower. Okay. The next thing you want to keep in mind, which is your third priority, is electrolyte replacement. That means once glucose levels falls below or equal to 250 milligrams per deciliter, we switch to IV fluids with dextrose. I'm talking about D5 normal saline, and we can give that. Always remember that as you're giving all of these fluids, keep your eye on potassium. And if potassium should go down, you will give potassium. So it's given as a PRN order. Next, you want to give IV sodium bicarbonate to treat severe acidosis. Now, the next thing that you want to keep in mind is that especially DKA patients die from hypokalemia, which obviously I believe I just said it not too long ago, because the condition of DKA is hyperkalemia. As we are treating it, we may then end up decreasing potassium, putting the patient at risk for hypokalemia. So that is for DKA. So let's go to HHNKS. The treatment is almost the same as DKA. Okay? Treatment is the same. Please hydrate your patient. So we're talking about IV fluids, IV fluids, IV fluids. Normal saline is the drug of choice. And then obviously we can do some hypotonic solutions as well, but mostly normal saline. Next, which is your second priority, is insulin therapy. So we give insulin IV. Only regular insulin can be given. IV bolus, we can do IV titration, okay, as things stabilize. And then our third priority is to correct any imbalances related to any electrolytes. Now, what do we learn from here? When we have HHNKS that goes untreated, then a patient will be at risk for something. The major issue here is dehydration, okay? And therefore, the problem is hypovolemia. So, two things to keep in mind. Whenever you're treating DKA, monitor for hypokalemia. Anytime when you're treating HHNKS, monitor for hypovolemia. So then, what are some of the causes of DKA and HHNKS? Let's take DKA first. It can be triggered by the following. Number one, inadequate insulin therapy. It could be illness or infections, severe dehydration, people who experience physical or emotional trauma, and sometimes certain medications can be a trigger. HHNKS is a little different. Again, triggers could be infections, pneumonia, UTIs. If your diabetes is purely, I was going to say poorly managed, I said purely. So poorly managed diabetes can lead to that. Certain medications such as the glucocorticoids, I'm talking about your corticosteroids, and some diuretics, Lasix, obviously. Severe dehydration is the major culprit over here. Other medical conditions, our own heart failure and kidney diseases. So let's go straight and talk about prevention. So this is where nursing care comes in. So you are the nurse, you're taking care of a patient with DKA, taking care of a patient with HHS. What do you do? So to prevent DKA, it's very, very important to monitor the patient's blood sugar levels regularly, follow the diabetic treatment plan, adjust insulin dosage as needed, and the patient needs to stay hydrated and manage what stress, because stress is a vasoconstrictor. In the case of HHNKS, it's always important to, number one, monitor blood sugar levels regularly, follow the diabetic treatment plan, stay hydrated, and always seek prompt medical attention if one notices any changes in symptoms. So now let's go to certain things we need to know for NCLEX. So these are your 5 targets. Number one, what are the 3 classic signs of diabetes? What are the 3 classic signs of diabetes? I'm giving you just 5 seconds. So answer that for yourself. The time is ticking. All right. So we have polyphagia, polydipsia, and polyuria. So those are your 3 levels of P, okay? The classic signs. Tremor, diaphoresis, and acute change in mental status are signs of what? Is it hypoglycemia or hyperglycemia? 2 seconds. I hope you got it right. So it's hypoglycemia. Now let's look at the third one. To treat hypoglycemia in an alert patient or client, give how many grams of carbohydrates and recheck the blood sugar in how many minutes? And what if the client is unconscious? 2 seconds. You thought I was going to give you 5 seconds. Nah, 2 seconds. All right. I hope you got it right. So to treat hypoglycemia in an alert patient, give 15 grams of carbohydrates and recheck the blood sugar in 15 minutes. So, especially when it comes to hypoglycemia, it's all about 15, 15, 15. Remember, 15, 15, 15. Now, what if the patient is unconscious? What about if they're unconscious? So, that is when then we give what? Glucagon IM to the patient. Number 4, clients with diabetes should inspect their feet. How often? And wear well fitted, something toed shoes. 2 seconds. All right, your 2 seconds is up. So, clients with diabetes should inspect their feet daily and wear well fitted, okay, closed toed shoes. Let's look at number 5. The 2 priority medications to treat DKA are IV what and IV what? During DKA treatment, monitor which 2 lab values and for signs of increased something. This one I will give you 3 seconds. So let's go. Okay, I think I've given you enough time, right? So let's take a closer look over here. So the two priority medications to treat DKA are IV fluids and IV insulin. So IV fluid and IV insulin. And it says during DKA treatment, monitor which two lab values. So the first one we're going to monitor is potassium. So monitor potassium levels. And then obviously the next one is also going to be monitor insulin levels. Monitor insulin levels. And look for signs of increased what? What do you think that would be? Especially with DKA. So we're looking at increased, especially with DKA, when this patient experiences that. So you're looking at mental status, what conditions, signs of increased. Again, it could be test. That is one. So test is something you can put over there. And then altered mental what conditions. So those are some of the things you want to what monitor. Now I want us to take a closer look at a few questions here. Now, most questions related to DKA and HHS, you have to apply Maslow's hierarchy of need. Okay, so what I'm going to do over here is to bring some level of understanding that when you are dealing with DKA, it's about dehydration. It is about insulin problems, right? Now, when you look at Maslow's, let's take a closer look at what the hierarchy states. Right at the base is your physiological need. So we're talking about your patient needs food, they need water, they need warmth, rest, they need air, oxygen. So those are the basic things that keeps the human body going, that keeps the cells going. So what does it tells you? It tells you that with physiological need, if they are not there, we are dead. The patient is dead. Cells are dead. So that our existence depends on physiological need. So when you are answering an NCLEX question, especially with priority, you always want to bring Maslow's into the picture. Okay? You want to bring Maslow's into the picture and you answer that first. Okay? So we have safety as the second uh, uh, um, level, which is security and safety. Belonging and love needs are number three. Esteem needs are number four. And the one at the very tip of the hierarchy is self actualization. Okay. So, what do we learn from here? You realize that the base is physiological need. Therefore, we're going to be using Maslow's hierarchy of need to answer the question. So, come here with me. This is your question. A client with diabetes has a blood glucose level of 700 milligrams per deciliter and is diagnosed with diabetic ketoacidosis. Which order should the nurse implement first? Priority. Which order should you implement first? So you have A, B, C, and D. So let's look at the A. Administer regular insulin IV as prescribed. B. Start an IV infusion of 0.9 normal saline. C. Administer potassium as prescribed. And D. Give sodium bicarbonate if pH is below 7. So basically, all these four items are going to be given to the patient. They will be administered. But the key point over here is what is your priority? Which one comes first? So that is where you need to bring in Maslow's hierarchy of need. And what does it tell you? It says the basic things in life. What is that? Fluid. Fluid. Okay. Fluid, you see fluid over there. We have air. Okay. We have rest. But in the context of what we see here, we are dealing with fluids. A patient with diabetes has blood glucose levels of 700 milligrams and is diagnosed with DKA. So when you look also at the concept of end, A and D, so what is the preceding sentence? Is diagnosed with. So our emphasis is on DKA. I believe we've looked at what is DKA, what is the treatment options for DKA. And the first thing we're going to do is in DKA, the problem is dehydration is a problem. We also have high levels of insulin being a problem. But the major issue is dehydration, which has to do with fluids. So the first thing you're going to do over there is apply Maslow's, and it's about fluid first. So your first tackle will be B. Start an IV infusion of 0.9% normal saline. That is our first priority. So we will do B. Then our second priority, we're going to go straight to the insulin because insulin impacts our fluid. So we're going to administer regular insulin IV as prescribed. And then as you are applying the insulin, keep in mind that insulin is going to have a significant impact on potassium because you know what's going to happen? Yes, insulin is going to open the cells. And now the potassium, the hyperkalemic potassium, will begin to enter the cell. So then we're going to put the patient at risk for what? Hypokalemia right there. So then your third priority is administer potassium as prescribed. And a lot of the time is PRN because we are observing, okay, what the potassium levels are. And then the last thing you're going to do, which is our last priority, is give sodium bicarbonate if potassium is below 7. So, if you are answering a question like this, your answer is going to be B, A, C, and D. That is the order in which you want to implement. We hope that you found this very educative, and we'll reach out to you with our next presentation. Have a good time.